Retinopathy of Prematurity. Informative video for parents and health staff. The retina is the innermost of the three layers that make up the back of the eyeball wall. It is a transparent, highly specialized membrane that covers the inside of the eye like a wallpaper. Its function is to receive the image formed on its surface and convert it into nervous impulses. It is similar to what a video camera does when sending the electrical signal of the recorded image through the cable to the television. In unborn babies, the retina is much simpler, and it requires very little energy and oxygen to function properly. These are provided from the choroid, the next outer layer of the eye. The retina then begins to mature, from the center to the periphery, to become a complex 9-layer structure that needs substantially more food and oxygen than it needed before. To supply these requirements, blood vessels grow in the same direction as the retina, from the center, and branch out toward the edges. The vessel's primary stimulus to grow is the lack of oxygen, or physiological hypoxia, felt by the retina that has just specialized and does not have adequate vascular support. Because the optic nerve is not located in the center of the retina, but rather off-center towards the nasal area, the path that vessels must follow is longer towards the temporal side, requiring more time to do so. In fact, in a full-term baby, the temporal periphery's retinal vascularization is not yet complete. It continues developing after birth. When a baby is born prematurely, both the retina and the blood vessels are not fully developed. Neither are the lungs. That's why prematurely born babies often require oxygen support to keep them alive, with their neurological functions integrity. In this artificially oxygen-enriched environment, the retina continues to grow, but it does so without the physiological hypoxia that the vessels need to keep growing. The problem begins after the baby's condition is stable, when they no longer require breathing or oxygen support. The retina is then fully matured and needs more oxygen and nutrients than the unfinished vascular structure is able to provide. This is why it begins to produce unusually large amounts of chemical stimuli for vascular growth. The most important one is the vascular endothelial growth factor. This excessive stimuli creates a disorder in the natural development of blood vessels, which causes retinopathy of prematurity, or ROP. Who can get this disease? The factors that increase the risk are many. However, the most important are three: low birth weight, lower gestational age, the more premature, the greater the risk, and oxygen levels in the blood. The first sign of the disease observed in the fundus examination of these babies is the presence of a well-defined line that separates the vascularized posterior retina from the paler anterior one without blood vessels. This is retinopathy of prematurity stage 1. If the disease is not controlled, this line rises, as if a row of bricks was formed on top, created by the intraretinal abnormally growing blood vessels. This is retinopathy of prematurity stage 2. If the release of vasoproliferative stimuli is not balanced by retinal vascular maturation, the disease can progress into the appearance of vessels on the retinal surface. So, instead of branching out within the retinal vessels emerge towards the surface, like a tree. This is retinopathy of prematurity stage 3. The neovessels are not normal retinal vessels. They have thin walls that bleed easily, and they grow within a fibrous structure that can contract, pulling the retina out of place. Partial retinal detachment is retinopathy of prematurity stage 4. If the fibrous traction advances, the retina gets completely detached, resulting in a funnel-shaped configuration that leads to vision loss, or retinopathy of prematurity stage 5. This progressive evolution to blindness due to ROP is the leading cause of early blindness in Latin American countries. However, this is not what happens in most babies. Frequently, this process limits itself by achieving a balance in which vascularization can progress naturally. Retinopathy regression happens first, and vascularization grows later, resulting in a regular retina, as if ROP had never happened. Since we cannot predict which babies will evolve badly, we have no choice but to examine them all. The examination is performed in the neonatal intensive care unit, or, if the baby was already discharged, on an outpatient basis. The periodic and timely examination is the only thing that allows us to detect babies who are unable to handle this disease alone and will need our help to prevent its progression. When we examine a patient with retinopathy of prematurity, we record our observations in a personal file using an international registration system. The International Classification of ROP has 3 parameters. The first one is the severity of the disease, in stages, according to the previous description. The second is its location, in a scheme of 3 zones centered on the optic nerve. The posterior is zone 1, the intermediate, zone 2, and the temporal periphery is zone 3. Most serious diseases are from smaller areas, since there is more immature retina. The third parameter is the extension over the retina, which is measured by dividing the eye's circumference in hours, like a clock. When the disease's characteristics indicate a risk of progression that could eventually lead to blindness, it is called retinopathy of prematurity type 1 and requires treatment. One of the most important characteristics is an excessive dilation and vascular tortuosity in the posterior pole, called plus disease. Laser is the most frequent choice of treatment. It is applied to the anterior avascular area of the retina. The immediate effect of laser treatment is to reduce the excessive amount of vasoproliferative factors that keep the disease active. As the days go by, there is a regression of retinopathy, and later the vessels advance over the treated area, completing the normal retinal vascularization. In patients who were very prematurely born, the disease begins when the part of the retina that's mature is very small. Retinopathy occurs in zone 1 or just in zone 2, and has a much faster evolution and poorer prognosis. This is called aggressive form, ROP-A. And here we must use an alternative treatment to rapidly stop its progression. This is the intravitreal injection of an anti-angiogenic drug. With this treatment, a substance that blocks the vascular endothelial growth factor is introduced into the eye, making the disease disappear in just a few days. This medicine lasts for about 4 weeks in the eye, so the patient must be closely monitored in case ROP relapses afterwards. This typically happens after the retina has advanced in its maturation, so it can be safely treated with a more peripheral laser. Blindness from retinopathy of prematurity can be prevented in almost every case. The secret is in the joint work of neonatologists, ophthalmologists, staff of neonatal intensive care units, and parents. We can all prevent it together.